Good afternoon. Will the captioner please test when you're able? Can we please have test captions when you're able? Thank you. We see the test captions. Thank you.
Good afternoon. Welcome, everyone. I'd like to go ahead and call the Health and Hospital Committee meeting to order at this time. I am Supervisor Otto Lee, Chair of this committee, along with Vice Chair Supervisor Margaret Abekoga. With both of us present, we have a quorum. So moving to public comment period is for the members of public to address this committee on items not on the agenda. Then you could go ahead and speak at this time. If you're in person, please go pull a card and submit it. And if you're on Zoom, please raise your hands.
I have no request to speak on item 2.
Okay, all right. We'll move on to item 3, which is approval of the consent calendar and changes committee agenda. Let's see. So on this one, I would like to request to place item number 6 on consent, which is a report from the Valley Health Plan relating to marketing and communication outcome measurements. And Vice Chair, do you have anything else? Changes to it?
No, that's it. Happy to make a motion with change of adding number 6 to the consent calendar.
All right, I'll go and second that. Do we have any public on that item?
No request to speak on item 3.
Okay, let's close that and take a vote.
Vice Chairperson Abekoga?
Aye.
Chairperson Lee?
Aye as well.
Thank you.
Good. Then moving to item 4, to receiving report on EMS system design concepts. And I believe we have Nick Clay, our Director and Chief of Santa Clara County Emergency Medical Services Agency. Good afternoon.
Good afternoon, Chair Lee and Supervisor Abekoga, and I'm joined by Assistant Director in Chief Mike Cabano and our Program Manager Tony Doe.
Great, thank you. Would you like to talk about, present? I mean, you've seen the report already. You have anything to add?
I would just, if I may, Supervisor Lee, highlight a few elements of the report, and
proceed.
certainly happy to answer any questions you may have.
Go ahead. Yeah, you want to speak about the highlights? Yes.
So I think one of the key things we want to highlight in this report is the verbiage of EMS system review or EMS system design versus the verbiage of RFP. So we really are looking at designing the EMS system, and RFP is a component of that, but it's a transactional component within that system design. So you'll hear us use those words sometimes interchangeably, but really are looking at the overall EMS system review. The goal today really is to help ensure that we are sharing concepts with you. We are drafting that solicitation that is mentioned, but really it's at a high level as a goal today to go through the concepts, receive any feedback you and Supervisor Abekoga may have, and then really there may be some draft language we have already, but not really in a position to share any draft language today with you. And then certainly happy to answer any other questions you may have.
Good, thank you so much. Let's see, any public would like to speak on this item, Jess?
Pause for Zoom. No, I have no request to speak on item 4.
Yes, Vice Chair, go ahead.
Thank you. Thank you very much for this report. Appreciate the update. I do have some questions, and I beg for your indulgence, Chair. We were able to do some outreach to some folks in our district, and so I'll just go by the subsections, and thank you for organizing it in a very organized way. Appreciate that.
Our pleasure.
The first one is in dispatch and communications equipment. There is a question about the AVLs in integration with Marvelous. My understanding is that our partners, regional partners, are moving away from the system and towards the tablet command system. Is there a way to bridge the existing systems to work together, or would we be able to move to a more regionally effective system for all EMS providers?
That's a good question. And certainly integration is our goal as we move forward with system design. There's been quite a lot of work and sort of proven reliability with Marvelous today, but happy to explore other options to continue the integration with both the providers and our stakeholders.
Great. So you'll just have that ongoing conversation, then come up with what would be the best system to work regionally on. Great. In regards to in the expanding access to healthcare and education section, there's mention of expanding access to non-traditional EMS services and a social service bridge program. Can you expand upon what that is and what you're looking for in the RFP.
Yeah,
around
absolutely.
that.
Thank you for that question. So the intent really, I think social services, we may be using that word a little loosely in the context of the county structure. So certainly not looking to replace, supplant social services as an entity or that engagement. But there are a lot of 911 calls or an increasing volume of 911 calls that are low acuity and where folks don't know who else to call, so they call 911. And they may be for things that may be a connection to social service entities or social service networks. So the goal is really to look at expanding and leaning into that proliferation of calls that are low acuity and making a connection point so that person may not need an ambulance transport or an ED visit, but they may need pharmacy refills or access to food or whatever that may be. So it's just bridging that gap there.
Okay. So then what would you do if you had a call like that and you don't have to send transport, so you would divert them to Nurse Navigator or some of the
Something
other?
similar. In today's environment, Supervisor, really when you call 911, it's the response of an engine and an ambulance, and their only option really is to take you to the hospital. So it's trying to find ways to expand those options to reduce the burden on the emergency departments while also expanding their access to other non-traditional healthcare.
Okay, great. In the innovations and enhancements section, you call out programs that address defining the needs of specific patient populations in a local community. How would you address defined needs that are not supported by a published needs assessment? I know we have like the Latino assessment, the API one, but the other groups of populations I'm thinking about is like geriatrics or youth or LGBTQ.
Certainly, Supervisor, thank you for that. I think certainly, obviously, we lean on the established reports. It's a wealth of knowledge for us to lean on. As those are non-established reports, there's certainly a number of metrics that both public health and our health and hospital systems do to gain information about those populations, as well as direct outreach, reaching out to you and city leaders to figure out where are their gaps that they see with their communities and trying to find opportunities to bridge those.
Okay, great. The integration of first response providers section talks about the agreements between the primary ambulance provider and each fire department. And in speaking with some of our community partners, there's a request to change that to make it into contracts with county EMS. And that's so that we can preserve the ability to place resources and service if a response time by the contractor exceeds our targets in certain areas. So could we look at that change?
I think what we're envisioning there is basically a three-party agreement that includes the provider, the county, and the local jurisdiction. One of the things that we've heard over the years on the part of the cities is a desire for compensation from the provider. That really has to be an agreement between the provider and the jurisdiction. And so that's a pretty significant piece here of what we're hoping to shift towards, so that the provider is then essentially treating those jurisdictions in a more similar manner to the way that they currently treat the other ambulance providers that they surge into the system. But that has to be a contract really between the provider and the local jurisdiction.
Can we, as the one that grants the contract to the provider, make that a requirement that they reach agreement with the?
Yeah, I mean, we can, that's why I said it would be a three-party arrangement, because we would need to
Be
be
a part of that.
involved
Okay.
and consent and be a piece of that. But that, we don't want to be an intermediary in the financial transaction, right? So one of the facets of the current structure that I think has been somewhat challenging is currently the county, through the EMS Trust Fund, is a bit of an intermediary fiscally between the provider and the jurisdictions for certain of these items. And we would like it to be a direct financial relationship.
Okay. Okay. And then along those lines, I guess I'm trying to envision how this would work. And Now that some of the cities have their own ambulances, in terms of like response time, how do we make sure that, right, the closest ambulance or the ambulance from that community where the call is coming from is the one, if it's available, the one that goes out? It seems like Marvelous or whatever system we use helps in that regard, but just, how do we make sure that?
I think we do think it's critical that all the resources be visible to and centrally dispatched, which is a core facet not only of what's described here, but actually prior actions the board has taken as a core piece of whatever the next RFP looks like.
Okay. Okay, great. That's it for now. Thank you. Appreciate it.
Thank you.
And I actually do not have further. I'm certainly looking forward to the next stage. So this is still very preliminary at this point, but certainly looking forward to the next stage when it comes back so we can have a much deeper dive onto the design. But thank you so much for the update for now, and looking forward to see it.
Our pleasure. Thank you so much, and we'll continue to engage with all of our stakeholders as we go through this process and get their input as well.
Great. So Vice Chair, may I get a motion to accept the report?
Yes, I'm happy to make a motion to accept the report.
And I'll second that. Let's take a vote.
Vice Chairperson Abe-Koga?
Aye.
Chairperson Lee?
Aye as well.
Thank you.
Thank you.
Thank you.
Moving to item 5, which is receiving a report from the Santa Clara Valley Healthcare Integrative Medicine, and we have our CEO of our SCVH, Paul Lorenz.
Thank you, Chair Lee. Supervisor Abe-Koga. Joining us today is our CMO, Fong Nguyen, and Dr. Jenny Biller, who's leading this program.
Good afternoon, Supervisor and the board.
Afternoon.
You have our written report, and we are happy to answer any questions.
Good. Let me see if there's any public who'd like to speak on this item.
I am pausing for a moment. This is item 5, integrative medicine. Right now I have 2 requests.
Let's do 2 minutes each.
Okay, our first speaker is in chambers, Mike Rogers. Please approach the podium.
Good afternoon. Can you hear me okay?
Yes.
I'd like to thank the county leadership for really embracing this and moving forward, especially the supervisors for being driving forces. I'm the chair of the Health Advisory Commission. We've been investigating this and helping continue to work with these guys. We brought in Eric Chen. I've had several discussions with Eric directly. We brought in Dr. Chris Magrita recently, which was phenomenal, long meeting with the task force directly about his model in North Carolina. Successful. Both of these are large, successful Medicaid programs for large safety net populations. Here's my advisory positions. I'd like to see the next expansion to be a broad-based syndrome, like, for example, metabolic syndrome. We've got women's health, we've got pediatrics doing more integration and stuff. Hey, these are the types of things that are safety net population, diverse ethnicities. More than 90% of the people in the county that were supported by this system suffer from these conditions. Secondly, grants are really important for systems like this to get off the ground. Chris Magrita, Dr. Chen, their first help was having a little bit of breathing room to be able to work on organizational boundaries, right? In fact, Dr. Chen said, hey, I had a supervisor basically tell the Alameda Foundation, give them a grant to get Food for Medicine off the ground. Now it's a stellar program for the whole state, right? And we're continuing to look at how do they're even offering us potential services, et cetera. The other thing is it's challenging because there's silos in SCVH, right? We have to figure out how Chris Magrita works great across his organizational boundaries. They're tuned across disciplines, right? And they support even when they don't have the funding. Somebody doesn't have coverage, they have the ability to say, the right thing to do is treat this patient. Same with Dr. Chen, because he has some flexibility because of the grants, right? And then finally, I'd like to see a roadmap for how the expansion rolls out. How do Supervisor Abe-Koga's request, how do these services become generally available? Thank you.
Thank you.
Our next speaker is Ken Horowitz on Zoom. We'll open your microphone. And you'll have 2 minutes. The timer will start when you begin speaking.
Good morning, can you hear me?
Yes.
Yes, this is Dr. Ken Harwood of the Advisory Committee. And we got this proposal out about 4 years ago, just after the pandemic.
Yeah, Dr. Horowitz, would you mind try to readjusting the mic? It's very garbled. You can start over again? Yeah, thank you.
Okay, I'll try it. I'm that comfortable. Make it clear. We got this proposal up 4 years ago, just after the pandemic. It's time to put the boots on the ground regarding this proposal to get integrated medicine. As a culture for Santa Cruz Valley Healthcare, the cost of care is going up and up and up, and we'll never reach the point where the finances will the assets. So we have to try things differently than we've been doing. I hope you put forward a recommendation to get the climate moving forward so that integrative medicine can become a culture within Mountain Health Care. And I think the strategies that are being proposed are good, but they'll only work if there's action. Words don't do enough. Action is key. So let's put the boots on the ground. Let's get it started. Thank you for your time.
Just a note from the clerk that Mr. Horowitz did also submit written public comment
Okay.
that you can refer to.
Very good, thank you. Okay, let's close the public speaking part on this one. Yes, Vice Chair, you have any questions on this one?
Thank you, Chair, and thank you for continuing this conversation. I know Chair and I are very interested in integrative medicine. I think you've heard us over and over say that. So I appreciate that we're continuing to pursue this. As mentioned by our Health Advisory Commissioner, I too am interested in maybe a more detailed, concrete roadmap on how to move the IM forward. So I would ask, like, what are some concrete steps that we can take in the next year to increase the adoption of IM practices within our provider, beyond the provider education that we're doing?
So I have been meeting with people, all the physicians from different departments. As you know, integrative medicine, it's about collaboration between specialties. And so we're very fortunate to have a healthy lifestyle program in pediatrics department. Okay. And so we're going to, the adult medicine side is trying to collaborate with the pediatric side to create a similar program. We have written up a proposal for healthy lifestyle and metabolic syndrome management program. You know, of course, the proposal is done, but we still need to work out the details about how to go about implementing this program, which will be similar to the medical bariatrics program, but different in that we'll put everybody from, you know, we'll have nutritionists, social worker, and hopefully psychologists all work together to really focus caring the patients who have very complex metabolic syndrome, like complex diabetes, poorly controlled high blood pressure, kidney disease. And those are the, you know, it's not going to be easy and fast. I'm not going to be able to promise you, oh, by the end of this year, you're going to see this outcome. But I can tell you, we are actively working together with various departments, including the Office of Sustainability and Resilience. I understand they're working on a food management system.
Yes.
And we've been working with her and Dr. Stephen Chen from Alameda County to set up our own medicine, food as medicine program. And as you know, that's going to take a few years again. But you know, it's just great because we have a lot of people in our in our hospital system, healthcare system, who have different areas of expertise. And I think right now we're starting slow because we're still exploring, what's possible without spending a whole bunch of money to hire new people. We're trying to build bridges between different departments so that we can all collaborate and work together. So, sorry, I don't have a really good, concrete roadmap, but I do have a 5-year plan that
you do?
is forever changing. Every few weeks, it's a different 5-year plan. But I'm happy to send it to you.
That'd be great.
It's completely a draft.
Yes.
It's not,
No, that's fine.
it's not ready for prime time.
Yeah, that would be really helpful. And I very much understand it's iterative. But to have that, and even if you can share that in our updates, at some frequency, that would be helpful just to see it evolving and moving forward. But so I would. My other question was that what are the primary operational and cultural barriers that are preventing the broader integration of IM?
I think the barriers we have in our healthcare system are very similar to all conventional healthcare system. We are very, we treat patients as diseases. So if you have a kidney disease, you go to the kidney doctor. If you have eye disease, you go to the eye doctor. Although we have a primary care physician, but the primary care physicians usually just send people off. We did a referral, and then you don't really communicate with the other doctors. So I think there's the biggest barrier is really the American medical system. Our culture is such that because we are fee for service, you provide a particular service, you get paid. So it's not, our systems is not set up as though we can collaborate easily. We have different call centers, like the nutritionists who are working with the bariatric clinic. They're under nutrition department. They're not part of the bariatrics program. Just even the call center and all those things. I don't think we can solve that problem quickly, but I think we can definitely reimagine a different way of delivery our healthcare. I really think we have we're very fortunate in our county. We have a lot of resources, not just money, but also people.
Right.
And
yes.
I think that's the problem is we don't know what the other person is doing. And I'm very happy that I'm working with the public health department and I'm working with the Office of Sustainability and Resilience to really learn what they're doing, how what they do can help the healthcare system as a whole. But that's going to take time.
Sure. Yes. I know that it's easy to be in silos, and
Yeah.
this is really about breaking down those silos. And I do understand it'll take time, but we just have to keep working at it,
Yes.
right? So I know that one of the challenges is reimbursement. But I do hear about Alameda and that they've been successful in this. And are there some best practices or lessons learned that we can gain from what Alameda is doing?
The main thing with the Alameda program is the Food is Medicine program.
Okay.
Dr. Chan was able to pull all the small farmers together and create a workflow to implement so that we can actually deliver medically tailored, medically prescribed meals to patients. Yeah, so that's what we are trying to do for some of our most vulnerable patients. And the reason we're trying to do that is because, food insecurity is a big problem right now.
Right.
So we're trying to, instead of just telling patients you have to eat healthy, you're trying to create a system where we can actually provide
Prescribe
healthy food. And so that's the main part of Alameda County where we're kind of learning from.
Okay.
And the best practices, honestly, we're still doing visit, like fee-for-service, we are FQHC sites. So each time the patient come, we bill based on their medical problems.
Okay.
You know, based on their visit. But I think what we are trying to understand is the alternative things like acupuncture,
Yes.
chiropractor, and how will those be reimbursed? And as of right now, I actually found out a couple of our primary care physicians just got their acupuncturist license.
Oh,
So
nice.
it's one of those things. Once again, if we didn't ask, we didn't know, right? So now I'm like, oh, okay, we have people like that. Then we can probably start exploring different reimbursement models. And we do need to talk to the health plan about the budget they have for
Okay.
food is medicine. Yeah,
Yeah.
program.
Good. Oh, great. Thank you so much. Appreciate it. Thank you, Chair.
Go ahead, Paul.
Thank you, Supervisor Lee. Supervisor Abekoga, I think to your request about a further defined roadmap, that's something that we can work with Dr. Biller and Dr. Nguyen on and bring back in future reports.
That'd be great. I appreciate that. I like to have timelines and, goals and just see where we're headed. And so having something like that to just check in on would be really helpful. Thank you. Thank you, Chair.
Thank you. Well, on that note, regarding you mentioned acupuncture and chiropractic services, California is one of the few states that recognize, acupuncture, and I would love to learn more about the reimbursement side of it on the revenue, since we're so tight on the money side, and how we could enhance that reimbursement, because we know it works. It's something that, like you said, they don't necessarily teach that in medical school, but that doesn't mean it's not something that's useful. And in this case, that's what integrative medicine is. There's a lot of these things they don't teach you in medical school turns out to be something that's very, I always tell people, what type of clinical studies do you have acupuncture? Well, we only have 5,000 years of it, so I think it was proven. So for that matter, I really think we need to encourage more usage of it and not make it look like a kind of a cult, like weird studies, oh my God, all these needles, that's scary stuff. Like there's a lot of people are not exposed to it would have that initial feelings. But we've of course seen many very beneficial practices. And as we all know, a lot of our drug addiction problem we have, it's on what I call irresponsible pain management. Providing people with these very highly addictive painkillers for the past decades. And these are so-called, proven medical practices and acceptable FDA-approved medications, and now we have a huge bunch of addictive problems we're dealing with. So I think these type of alternative ways to deal with pain that does not lead to these type of addiction is truly necessary. So I just want to mention why I think it's so important that we adopt these practices sooner. And a lot of times, I understand people, have medical degrees, have practiced for a long time, but understanding some of these alternative practices is truly important. And so I just want to thank you for coming here and discussing what you're working on. Yeah, looking forward to the roadmap that you have ahead, and certainly want to make sure that if we can reimburse for any or all of it, that would be amazing. Okay, thank you. So again, thank you so much for the report. It's truly excited. We're moving forward. I'm looking forward to future reports to work on the now incorporated fully throughout the hospital system in the future. All right, do I have a motion to receive the report, please?
Yes.
Now
Make
we'll
a
second
motion
that.
to.
Thank you.
Vice Chairperson Abekoga?
Aye.
Chairperson Lee?
Aye as well.
Thank you.
Thank you. All right, moving on to item 7, which is receiving a report relating to efforts to establish a mobile medical unit on the De Anza College campus.
Thank you, Chair Lee. I'm
Hey, Paul.
very pleased to share with this committee and, of course, the community that we will be launching the mobile medical unit at De Anza College campus on May 6th. and it will be there every Wednesday. And we will continue to monitor the utilization and adjust our schedule as needed to serve that community. So with that being said, I'm very pleased to share that and happy to take any questions from this committee. And also Celine Ho, our primary care director, is also with us, who has been wonderful in bringing this about.
Great. All right. Do we have any public who would like to speak on this item?
I have no request to speak on item 7.
Yes, Vice Chair. Any questions?
Thank you, Chair. Just really a big thank you to Paul and Celine and your entire team for making this happen. Being just over a year into this role, government doesn't always work slowly. This is quite an accomplishment, and I really appreciate the hard work that you put into making this happen. I know the community's been asking, when's this going to open? So now we can tell them when it's opening. But and I really appreciate the county working with De Anza College in that partnership. I think is very valuable. So just a question in terms of what services you expect to have available in them.
Celine, why don't you come up and respond? Although I can, I think, given all the work you've put in.
Good afternoon, Supervisor. Yes, we're providing primary care services, and so routine checkups, sick visits, vaccinations, lab testing, and then obviously referral to a medical home within our primary care network if they don't already have one.
Great. Thank you. And then in terms of promoting the MMU, what are some of our plans to do PR? And maybe that was item 6 that we put on the, or 7, but yes, how are we going to promote the usage?
Yeah, so now that we have a launch date, we've been working with our marketing department to create some outreach materials. Our team is going to be on site at De Anza College as well to let the folks know that where our MMU is going to be parked.
Okay, great.
And the hours. Of course, it's also for our surrounding community as well, and so we're going to try to do some grassroots outreach, posting in social media, also providing it at community centers in and around the area as well.
Great. Well, thank you. And we're happy, our office, to help push it out too through our channels. So, and I know there's a grand opening being planned. So thank you. Thank you again. Really appreciate all of the work. Thank you, Chair.
Hey, thank you. So this pilot program is scheduled to last 1 year, and the MMU will be open once a week on Wednesday. So is that the expected length of pilot is 1 year?
Yeah, we're starting out with 1 day a week. We want to see what the volume looks like and what the service needs are, and we'll see if we need to adjust once we launch and see.
Well, exactly. So if it turns out that the service seems to be very popular, it would be possible to increase it to twice a week. Let's say if we start on Wednesday, maybe Wednesday and Fridays, twice a week in order to meet some of the needs. Because I know for students, if I recall the days and students, Friday tends to be the day of the least classes, for example, right? So that might be easier for the students to access this service. So is this something that could be done, let's say after 3 months, if it turns out to be so popular?
Yes, we will definitely take a look at the schedules and see if we need to adjust.
Okay, good, yeah. When do you think you'll come back to give us a quick overview of how things are going after it started? About a quarter later or 6 months?
Yeah, we can probably do a quarterly update with the initial launch and see if there's any adjustments that we need to make.
Okay, so you're starting around April timeframe, Q2,
Right.
right? So maybe around June or July. Well, July is our break.
Yeah, starting July, I think would work. Or
Yeah, July, there's no board meeting, right?
Right, there's,
Right,
yeah.
So August?
August.
So maybe the update could be August timeframe. If you come back to us, the next week's meeting, that would be great. Yeah. Perfect?
Yep.
All right. And that's all question I have, all the questions I have, so may I have a motion?
Yes, I'll make a motion to receive the report.
Yes, so
Thank you.
report as well. I'm not going to add as a motion, but looking forward to the pilot preliminary results by August. Thank you so much. Let's take a vote.
Vice Chairperson Abikoga?
Aye.
Chairperson Lee?
Aye as well.
Thank you.
Thank you. Moving to item 8. Which is our, let's see. Yep, so it's the report out from our county health system. I think, Paul, you're first on this one. You have anything else to add?
Just a few items. Obviously, you have our written report, but I did want to point out a few things. First, as you well know, that our South County Children's Advocacy Center broke ground or started construction. So we're very pleased with that. And as you know, it's modeled after the CAC in San Jose, which has been very successful. And it will deliver trauma-informed medical evaluation, forensic interviews, investigative services, and family support services in one location for our South County residents. And obviously, this has come about because of a very deep partnership with the DA's office and multiple other community-based organizations in our community. So we're very pleased that that project is moving forward. I think this is also an important note that is included in the report. The breast center at Valley Medical Center has expanded our capacity. We've seen a 51% increase in our visit volume in our health system since we've added the second surgeon. This growth eliminates the need for our system to redirect to outside providers.
Great.
The breast center is nationally accredited by the American College of Surgeons, the National Accreditation Program for Breast Centers. And right now we treat over 200 women with breast cancer in our system.
That's great.
In terms of their ongoing treatment. Your health system has seen strong operational demand across the health system at all of our hospitals in the areas of emergency care, inpatient, and specialty care. The emergency department visits are up approximately 15% since July of 2025. And inpatient utilization has increased about 7%. Obviously, this reflects sustained community reliance on and growing reliance on your healthcare system.
Right.
I also wanted to share that Santa Clara Valley Healthcare is on track to receive 100% of our Quality Incentive Program, our QUIP funding. This is the supplemental funding that we receive from Medicaid. That represents about $170 million annually. So this really reflects our ability to not only meet quality metrics and to achieve the revenue associated with that. The system ranks in the top decile nationally on most Medi-Cal quality measures. So we're very pleased with the performance of our clinical staff and our staff within the healthcare system for that incredible progress relative to those achievements. You should also know, and this is one of our budget initiatives that we had presented at mid-year, Santa Clara Valley Healthcare has earned the American Diabetes Association certification for diabetes self-management education and support, which actually allows our pharmacist-led diabetes education program, when they conduct visits, to become billable for the first time in our system. So just having that accreditation and certification allows us to bill. And so between November of 2025 and January of 2026, just for that short period of time, your 4 accredited Valley Health Center sites have generated about $750,000 in additional revenue, new revenue for the health system. That's for a 3-month period of time. So that gives you an idea of some of the initiatives that we're implementing to ensure that we maximize the revenue for our health system and the county.
Is this ongoing, Paul? So 750 and times 4, we're talking about $3 million a year.
Yes, and that was our proposal that we provided to you. So that gives you an idea of how we're going about trying to ensure the continued delivery of service, but also generate the revenues to maintain the system. So I thought that was really important to share with you, because there's been a lot of discussions of initiatives that we put forward. And the last thing I did want to share, and I think both of you are aware, but O'Connor Hospital was also recognized as an age-friendly health System Hospital for implementing the 4Ms framework, which is what matters, medications, mentation, and mobility. And this is the framework that is an evidence-based approach that promotes safe, coordinated, and person-centered care for our older adults population. And so while it's starting at O'Connor Hospital, this is something that we are moving towards from a system-wide perspective to better serve our community and our aging population. With that being said, I'm happy to take any other questions, but again, thank you.
No, thank you, Paul. Those are certainly great update and the so many award-winning issues. And as always said, is that if we don't toot our own horn, the critics will say it for us and give people the false sense of problems of our health care that we're providing. So what can we do to promote these good news, both in the social media and the publicity wise, and two is can we hang these things on our walls when our patient visits at VMC or other clinics?
Supervisor, so we do have our marketing and communications group, and we do promote these accomplishments through our social media and our website. And we do share this as we communicate with our community-based organizations and our partners so that they're sharing in this good news and success as we move forward. But that is something that we will continue to do to further promote and ensure that these acknowledgments do not go unnoticed.
Yeah, I think it's important to do that, and even in our email signatures, besides saying who we are, just put down the awards that we're winning and stick those labels. And I mean, every little thing helps, right, to help promote these good news that we are receiving these great awards. I think it's upon us to tell the story, and so yeah, please continue doing that, and anything we can do as public officials to say those things, and all the various public engagement we have, we're certainly happy to incorporate in our speeches, right? Yeah. Okay.
We'll do that. Thank you.
Thank you. All right. Yes, Dr. Redmond, go ahead.
I was going to jump in on the next item.
Sure, please.
Okay.
Absolutely.
So just on behalf of the Public Health Department and the Health Officer Report, I have two topics just to cover very briefly. The first is just that since this body last met, we did have the county's first measles case of the year. And normally we don't talk about first of the year because it is such an unusual event. But this year, I will not be surprised if it's not our last. Fortunately, because of the structures we have in the Public Health Department, and frankly, because of the very high immunity rates due to vaccination and distant infection for older adults, we were able to quickly get our arms around this case, reach out to many exposed persons, make sure that we knew their immune status, keep them out of high-risk locations like hospitals and schools until we knew that they were unlikely to get sick, and to keep this disease from spreading. So huge note of gratitude to the public health staff who helped with that response, as well as our collaborators in San Mateo County where there was an additional exposure. And then the second just has to do with vaccine news in general. The first is to make folks aware that we are experiencing an unusually late year for RSV, respiratory syncytial virus. This is a virus that spreads every winter, but usually peaks in January and can be especially dangerous for older adults, but also for infants, especially newborns. And we know that it is one of the #1 causes of hospitalization for infants, including here in Santa Clara County. But fortunately, 2 years ago, we developed or got access to a new shot that helps keep babies from being seriously ill. So because of the late season this year, normally we say a baby born after March, or if your baby was born this winter but hasn't gotten that shot, you're good for the year. We'll worry about it next year if you're particularly medically vulnerable. But this year, California has said babies born all the way through the end of April or babies born this winter who haven't gotten their shot yet should still get what's called a monoclonal antibody shot, a shot that helps keep babies out of the hospital from RSV. So we're working hard to get that message out to pediatricians, obstetrics providers, folks expecting to deliver in the next 6 weeks, so that everyone knows that we're recommending this additional layer of protection this winter, but later into the spring, or what feels like summer right now. And then finally, I'll just say that I'm sort of watching closely and appreciating the current status of the lawsuit between the American Academy of Pediatrics and the ACIP, the CDC and HHS more generally at the federal level. During which this week a judge found that the process that the federal government used to make drastic changes to which vaccines are available across the country did not follow a scientific or legally rigorous and appropriate process. And so I'll leave the legal components to the true experts in the room. I will say from a scientific, a medical, a public health status, I think this is a win for the people of Santa Clara County, even though California had already taken steps to protect our vaccine access. We want folks here in Santa Clara County to continue to have unfettered access to the vaccines that we know keep folks healthy, so we can get our kids back to school, back to soccer practice, back to enjoying this weather, and out of the hospital.
Right. Great.
And I'm happy to take any questions.
Yes, thank you. Let's see. Yes, Vice Chair, go ahead.
If you have other questions, I have a completely separate question topic.
Okay,
is that
sure.
okay?
Let me
If you have-
start
yeah.
with this one. Going back to the issue of measles, most of us already have our measles, actually it's our combo shot, the MMR, mumps, measles, and rubella, right?
That's right.
And but of course, many of us also got them a long time ago. And so how do we get measured to see whether a booster would be needed? And how do people get the booster?
Sure. So there is a blood test that can help figure out if your body shows immunity to measles, whether you're in that vast majority of people after a shot or 2 shots who are immune for life, or could be in that very small subset who didn't show immunity. However, given how effective the 2 vaccine shots are when you've had 2 shots, we don't recommend everyone run out and get that blood test.
Okay.
We recommend it specifically if you don't know if you've ever gotten the shots or you think you may not have. Or we recommend it for certain folks who have serious medical illnesses that may have impacted their immunity. Or for folks who may have grown up at a time when they were never vaccinated and don't know whether they ever had measles. So it's really a small subset of the population we recommend get that blood test right now. Now that changes if we find out you've been exposed and we don't have a record of your shot. We often very rapidly stand up public health resources to get blood tests so that we can be sure who's at highest risk of getting sick and keep folks safe when that happens. But in general, the more important step for everyone to take right now is to check your vaccination records. If you've got a record that you had 2 shots, especially because we have such a vibrant immigrant population here, a lot of the times that was a requirement for immigration, and so folks have fairly recent records. If you've got that record, I'd say there's nothing more for you to do right now. If you think you were not vaccinated or you grew up long enough ago that you're not sure, that's when it might make sense to talk to your doctor about whether the blood test makes sense for you. The last thing I will add, if I may, is that right now, all across this country and other places that historically have very low rates of measles, we don't recommend your first measles shot until you're a year old. But the exception to that rule is if you're traveling somewhere where there's an outbreak. We used to say that was mostly in other countries, but now it includes places in the US. Parents may want to consider vaccinating babies as young as 6 months, just to make sure that, because the shot does start to help at that point, you can give an added layer of protection if babies will be traveling between the age of 6 months and 12 months. And we want to be sure that in their travel to a place with higher rates of measles, they have that layer of protection.
Great, thank you so much.
Can I ask about that?
Go ahead,
please?
yes.
This might be a stupid question, but I'm thinking, given my age, I'm 55 and probably got the shot when I was a baby. Or how do those records transfer over? And then I'll say too, because my family didn't have health insurance, me growing up, my care was a bit spotty. So yeah, how would I be able to check that?
There are systems that will sometimes help us look into historical vaccination records. I know we recently received a request for somebody who grew up in Santa Clara County, I think around 40 years ago, and we were able to dig something up for them. It really varies, so I don't want to make a promise that we'll be able to find a particular record for someone who grew up in this area in California. What I will say is that systems to do so have improved drastically over the last 20 years. There's a system called CARE, basically the California Immunization Registry, that allows us now, the second you get your vaccine at one of our county hospitals or another healthcare system, it automatically goes into a statewide system where we can check for you. So if you did grow up elsewhere in California, I can find that information for you. So it may vary. If you've got those old yellow cards somewhere, it's worth digging up. It may be worth talking to your old doctor, but it may be as simple as we can find it in the statewide system because we've been working to bring legacy data into those systems wherever we can.
So if you're, I know that like when you're going to college, there's certain checkpoints in your life where you have to have been vaccinated to move in there. So if you've been going through that, then, or I don't know if, I can't remember if there was one when you're, pregnant or getting ready to get pregnant, but are those
Yes, that's a great
indicators
point.
that you're most likely vaccinated?
And one more reason why it's so wonderful when folks are engaged in comprehensive primary care, because it does create those opportunities to regenerate those records and check up on it. So in pregnancy, actually, it's a different component of the MMR vaccine we're worried about. We're most worried about rubella because it can be harmful to a fetus or a pregnancy. But we do often check into someone's vaccination record for MMR at the time of pregnancy, and that helps us update documentation when we can. So folks may have throughout their lives, especially if they had access to primary care, may have updated records. And if not, talking to your doctor about your personal risk right now, especially if you're traveling, you're having other health concerns, can help you figure out whether anything else is needed right now, or whether you fall into one of the groups that we presume immune, which is, again, the vast majority of folks in this area.
Great, thank you.
Sure.
Yes, so my other question, totally different topic, but something you keep hearing from me, is the community health worker program for the AAPI community. I know in April we're supposed to get a comprehensive report to the full board, but just wanted to confirm that that includes both the Latino and the AAPI community programs. And then are there opportunities, are you looking at merging the two for economies of scale?
Sure. So the report that will come back to the entire board at the end of April did come out of the Latino Health Assessment, and the data we gathered for it, both from a policy standpoint and an economic standpoint, to say what does it cost to invest in comprehensive community health worker access, and then what's the return on investment, both in health and savings, will capture a lot of the work that was part of the AAPI community health worker study, partially because Aki, our key partner in that, was a key contributor to the community health worker study that came out of the Latino Health Assessment. So you will see in that report policy recommendations, investment ideas, and mapping of what exists already that does overlap very significantly with what we think our, both the existing AAPI community health worker program led to and how to sustain it, as well as where it could go from here. What I will say is, because of the focus on the Latino community, some of the what would it cost to invest and expand in certain ways are focused by neighborhood, not necessarily by race and ethnicity, but on the neighborhoods that had higher rates of Latino community members or that were called out otherwise in Latino Health Assessment. So there may be some pieces that don't translate exactly, but others that I think will be hugely beneficial. So ultimately, I think there will be some really valuable insights about how to sustain and grow the AAPI community health worker component coming in that report.
Great, thank you so much. Appreciate that. Thank you, Chair.
Thank you. Dr. Terrell.
Hi, good afternoon, Chair Lee, Supervisor Abekoga. You have our written report. This responds to Supervisor Lee's request last month for an update on contingency management. So we provided some updates on the program, the number of individuals that are currently being served, as well as just how the program operates. So open to any questions you might have.
Okay. Thank you. All right, next I think is Laura. Hi. Oops, your mic's not on yet. Let's try one more time.
Sorry. Thank you, Supervisor Lee and Supervisor Abekoga. You have our written report, so please let me know if you have any questions.
Okay, no questions. All right, moving along. Now I think we have our Bert Margolin from the Margolin Group is here to give a report regarding federal and state health policy and budget landscape. Good afternoon.
Mike, there we are. Did you want to speak, Amy? No. Good afternoon. Yes, happy to be here to report out on these developments in Washington. Let me start by reporting on the limited government shutdown that's underway that was triggered by the failure to pass the Homeland Security appropriation. 260,000 DHS employees are involved. 90% of them, though, are still working, most of them without pay, but 90% are still on the job because of the essential nature of much of their work. There appears to be no immediate prospect for a deal, although there are negotiations underway. As everyone here knows, this shutdown or this failure to pass the bill, which led to the shutdown, was triggered by Democratic concerns about misconduct by ICE officers, and the White House and Senate Democrats are going back and forth. There are offers from the White House to do things like install body cameras or implement a body camera process, but they say things like they're going to increase the use of body cameras. Well, what does that mean? Does that mean you go from 1% to 6%? The Senate Democrats want everyone to wear a body camera. It's those kinds of issues that still separate them out. So that negotiation's underway. But that's sort of quiet negotiation. The louder and more public debate in Washington that started yesterday is about the SAVE Act, which is the Republican effort to make registering to vote and actually voting much more difficult through rigid new requirements that are designed to reduce the universe of voters in a way that Republicans think will benefit their party in the 2026 election. The SAVE Act has next to zero chance of passage because of the Senate's 60-vote threshold. But under pressure from the president, there's now Senator Thune, the Republican leader, has started a debate on the floor where for many days, perhaps for a week or two, there'll be a back and forth in which arguments will be made. And the hope by Thune is that that will satisfy the president. And in the end, he knows there aren't 60 votes for passage and the bill will die. President Trump and others want something called a talking filibuster, which would actually involve potentially months of debate on the Senate floor. And the theory behind a talking filibuster is that the Democrats would, at some point, break down and no longer be able to hold the Senate floor, and therefore, on a 51-vote basis, this bill could be passed. There's, I think, no way that Democrats will be less resolute than the Republicans in a talking filibuster. So even if that was to be pursued, the odds of success for the SAVE bill are, again, close to zero. So while the partial shutdown drags on, a bit of positive news, although it's very minor, is that the Senate is continuing to process the FY27 budget bills in subcommittee meetings. There's a normal bipartisan process underway. Hard to know at what point that goes off the rails, if at all, but that's currently on the rails and moving forward. Another budget item I need to report on that has potential implications for our health system and our health funding involves budget reconciliation. You may recall that at a previous HHC meeting, I said that President Trump had taken budget reconciliation, which was the vehicle used last year to pass H.R. 1, which has done so much damage to the Medicaid program and to California in general, and the nation in general, when it comes to access to health care. It's the 51-vote vehicle 51 votes in the Senate. Well, the president said it was off the table a month ago. I did say at the time, this president is known to occasionally change his mind, and that was, I said at the time, an obvious understatement. Well, unfortunately, reconciliation is back on the table for a couple of reasons. One factor is the House Republicans at their retreat a few weeks ago had a debate about this, and there's a block of House Republicans who want more tax cutting. They think that if they can do more tax cutting, which you need reconciliation to do, they'll have an additional argument to make in the midterms. An example of the kind of taxes they want to cut involves providing help for first-time home buyers, issues like that. So they want it on the table. But the other more compelling factor may be the need to pay for the war with Iran. Depending on the length of the war a supplemental may be needed to pay. I mean, it's impossible to know the cost of this war. Budget experts are estimating it could be between $50 and $100 billion if it goes only a few more weeks, and no one knows how long it's going to go. Getting a supplemental bill, a standalone supplemental through the Congress, will be incredibly difficult. Weaving that into the appropriations process will be equally difficult. So the president and Congress, the Republicans, may turn to a reconciliation bill. The danger, of course, with reconciliation from our vantage point is that you have to have offsetting cuts. So if they try to pay for the war with Iran with reconciliation, they'll have to find cuts. And again, our healthcare programs, already cut in a very severe and damaging manner, are once again vulnerable. Now, the argument against reconciliation happening, which is what was motivating President Trump a month ago, still stands, and that is the Republicans, even though you can pass it on a party line basis, they have razor-thin margins in both the House and the Senate. So even if the will is there to do reconciliation, it's going to be hard for them to get that done. On the health front, a couple of items worth noting, one of which Dr. Rudman has already referenced, and that's the Massachusetts federal court decision, which was really very good news. The lawsuit brought by the Academy of Pediatrics to block HHS from moving ahead with these vaccine policies, including COVID and childhood immunizations. What was especially heartening about that decision is that this judge very directly took on the fact that these recommendations were without scientific evidence, just stating plain facts. Where's the science? It's not there. But he went beyond that to also validate the notion that the committee that reviews these decisions, the ACEP committee, is composed now of a significant number of members who have no background in vaccine medicine or science. So you've got no evidence being reviewed by people without expertise, and this judge, and it was heartening to read this, to hear this, said, that makes no sense. Now, it's going to be appealed, and we know that in the court system, this may at some point be overturned, but it was a good development. And it actually, this whole vaccine chaos has had another potentially useful impact on Health and Human Services, in that the White House engaged in a shakeup of HHS leadership, not RFK Jr., he's still there. Mm-hmm. But some of the people below him responsible for some of this chaotic, non-systematic, non-scientific decision-making have left. And there's a man named Chris Klomp who was in charge of CMS, who's now been given responsibility as the chief counselor for HHS for broader operations of the agency. And he's described as pragmatic and apolitical. And again, there may be a desire to have a more rational decision-making process. Again, we're not out of the woods, but far from it. But it's just worth noting that there's been finally some reaction to some of these very irrational decisions that have been made in D.C. So we'll see how this all plays out on the vaccine front in HHS. I want to conclude by commenting briefly on what's happening at the state level. In that, we all know that Governor Newsom's budget in January did very little to respond to the impact of H.R. 1, and that Santa Clara County, other counties, other associations throughout the state have been developing strategies and advocacy plans to insist this year that there be attention paid to mitigating the impact of H.R. 1, not next year, but this year, because the impact is so severe. So County of Santa Clara, along with a number of other players, has put forward multiple asks. Just to briefly remind us all as to what they are, we want the self-financing by counties of the non-federal share of inpatient fee-for-service Medi-Cal to be done away with. And what that simply means is, for 20 years, counties like Santa Clara, in what's supposed to be a state-federal matching program, have put up our resources to draw down the match, diminishing money that would otherwise have been available to Santa Clara County, and to the tune of $500 million, where the CAPH, our statewide association, with the support of Santa Clara, is saying that has to stop, and we have to start that new process of having the state put up the match, the state do the investment now, because the mechanisms we've used for 20 years to make up for the loss of that state match are going away. They were the targets of H.R. 1. Second issue involves eligibility workers. We know that H.R. 1 is all about making it harder to become eligible for Medi-Cal, harder to become eligible for CalFresh. We need substantial new resources to strengthen that whole eligibility system, and the county is strongly behind that ask that's being advanced. And there's also an additional major ask involving a minimum of $2 billion from the state. That's the minimum number that the county has put forward to address the increase in indigent care and the number of uninsured who will come to the county once the full impact of H.R. 1 is felt, and people, it's starting now, but it'll be even stronger over time as the impact of H.R. 1 is felt and people no longer can either afford care or because of these eligibility restrictions and hurdles, they lose their coverage, and now they're uninsured or they're indigent. And it's a minimum of $2 billion statewide. So there are multiple asks. I believe that Mr. Williams is going to be testifying tomorrow before the state senate, and he can maybe tell you more about that to advance these issues and others. But again, that's something just worth noting in that this is a major battle and the stakes are very high for the county.
Yes, I will be in Sacramento tomorrow testifying for a Senate committee regarding the H.R. 1 impacts. We've had a very strong and visible presence. We are pursuing our three-part strategy of state legislative efforts to push back on H.R. 1, including maintaining people on Medi-Cal enrollment, supporting public hospital systems, and revisiting the state-county fiscal relationship related to indigent care. We are hoping that a very strong coalition that includes CSAC, Urban Counties Caucus, California Association of Public Hospitals, and many others will soon be coming together very publicly in support of basically those same prongs. And we'll be pushing that very strongly. I think we have gotten overall a very positive reception on the part of legislators who I think recognize how critical these services are and have been paying attention to the fact that Californians are now ranking health care coverage and affordability as the most significant concern, actually significantly outpacing housing and rent for the first time in many years as the top concern for Californians. And that's before we have actually seen a lot of people lose Medi-Cal coverage with the implementation of the work rule requirements. So this is just really what we're seeing from the immediate impacts and from the impacts on the health exchange as a result of the congressional Republicans not extending the subsidies. So this is our top priority and focus area. We're going to keep pushing hard on it, and we will be pushing all pieces of that approach.
That completes my report.
Thank you, Mr. Gould. Vice Chair, you have any questions on this one? Oh, yes, go ahead. We do. Oh, sorry. Public speakers, how many do we have?
I have one request to speak on item 8.
2 minutes.
Our speakers on Zoom. We'll open your microphone, parent. You'll have 2 minutes to speak. Please go ahead.
Yes, good afternoon to you all. Before we start tooting our own horn and posting awards on the wall, I think we need to recognize the severe issue we have here when it comes to child abuse and when it comes to providing screenings for children who've reported being abused. I mean, my own kids are being sexually molested. My son, he's confirmed that my ex-wife was letting a man rape him beginning at the age of 13. There'd been unnecessary bathing with the children. And there was sexual contact between two of my children. I had to separate them a few times, and it just screams, let's do a screening for the children. Why let the abuse continue? Because if the screening never occurs, you guys treat it as if the abuse is not happening. And it's like a sick practical joke to deny my kids a screening. I mean, you're all in on it. You all know what's going on. I mean, how many meetings have I been to? I mean, how many emails have I written? I mean, nobody cares. Nobody here in this room cares. I mean, like, the only email I've ever received back was from Wendy Kinnear Rausch, and she wrote one line. She said, if you want to file a complaint, you can file a complaint with our complaints division. She didn't say she was concerned. She didn't say, I'm sorry this is happening. None of that. I tell you guys, it's not safe to raise a family here in Santa Clara County. If you're single, that's okay. But if you have children, I believe we should tell everybody to move, to get out of Santa Clara County. Because if your children get raped or if your children get physically abused or anything like that, the county is just going to ignore you. They're going to pretend like nothing happened. They're going to blame it all on the federal government. It's the federal government's fault that children are getting raped. I mean, that's all I'm hearing here. You guys are perfect, and it's everybody else's fault. Thank you for your time.
That concludes public comment.
Thank you. Mr. McGowan, related to all the federal negotiations we heard about, like you said, the DHS funding being held up, and that we are seeing long lines at the airport right now for those workers, which is extremely unfortunate. At this point, you really don't see an end to this, do you?
I think they're not this week, not tomorrow, but there is a negotiation going on, and both sides are starting to make some small concessions. So I think at some point, especially with the long lines, as the pressure builds, and for other reasons, there could be an end to it. It's just taking longer than anyone would like, and the administration resistance to having things like body cameras required for all the officers. Why not for all of them? Why increasing without specifying how many are going to actually have to wear them? It's things like that that the Democrats have found frustrating. But again, they're talking to each other. They're exchanging proposals. So something could happen in the next several days or week or two.
So the advice is get to the airport early if it fly.
Yes, I did that this morning when I flew up here, by the way. I was there early for that reason and actually overheard some TSA officers talking about how difficult life was for them during the shutdown. And, it's obviously sort of a tragedy for the workforce, and we need to get this resolved.
Absolutely. Okay, thank you very much, Mr. Golan.
Thank you.
All right, let's see. I think if this point is actually bring us to the end of our meeting, correct? Yeah, and thank you for everybody that worked on this, admin and the clerk staff. The next HXC meeting is scheduled for Wednesday, April 15th, tax day, at 2 p.m. right here, same channel, same space. So thank you very much, and now meeting is adjourned.